And I'm the Director of Grant Making at the Maine Community Foundation. I also lead our strategic work related to aging and thriving older people. So I'm honored to have been asked to moderate this panel today on aging in place and telehealth. And I also want to thank AARP for sponsoring this panel so we can focus on this aspect of making use of broadband. So just a couple of context things to hopefully help set up our panel. In Maine, as many of you I'm sure are aware, we are on the leading edge of a demographic shift that's happening across the country, across the world. As a result of many of us living longer and healthier lives, and also not having as many babies as we used to. So by 2035 nationwide, it's projected that the number of people over 65 will outnumber the people under 18. And that, as some of you might know, has been the case actually in Maine for several years now. According to the 2010 census, Maine is the most rural state of the nation, with over 61% of our population living in rural areas. Our rural population tends to be older, and that's true in other states as well, with 58% of adults over 65 living in rural areas. So based on research conducted by AARP, we know that the overwhelming majority of people prefer to live in their homes and communities as we continue to age. The challenge for this is that our homes and our communities and our systems are not necessarily set up to allow us to do this with the optimal options available for everyone. So with challenges, there also are always opportunities for innovative solutions. Telehealth, also called telemedicine or virtual care, is one of these creative solutions that's gaining traction all across the country to address the quality and cost of care for those who have limited mobility or limited access to quality care, often based on remoteness. So one of the challenges of telehealth is that certain forms of it require broadband. And so that's, I think, why we find ourselves here at this broadband conference talking about it. So let's get to it. Our panelists include Cheryl Crowley, right here from Sustainable Cliff Island, Danielle Lauder, who's Director of Northeast Telehealth Resource Center, Chris Winstead, Executive Director of the Piscataquis County Economic Development Council, and Stephen Baybutt, Director of Population Health and Telehealth Services at MaineHealth Care at Home. So I'm going to let them each introduce themselves more fully and explain how their work intersects with this topic. After they're done, I'll get us started with a couple questions before opening it up to you. So who would like to start? Whoever's got the microphone.
So I have the mic, so I'll start first. So I'm Stephen Baybutt. I work for MaineHealth Care at Home. We're a home health agency affiliated with the larger MaineHealth system that you're probably all familiar with. The particular agency that I work for has been in existence for over 100 years, originally starting in the community around Kennebunk, Maine, eventually morphing and merging with other agencies into the agency that we are now, where we are a traditional home health agency. We offer nursing, therapy, social work services for infants, adults, the elderly, from Kittery all the way up the coast to Belfast and Winterport, and then all the way into the interior into Fryeburg, Maine. So that is a huge service area. We've been using telehealth in various forms for about 18 years, starting with USDA RUS funds in 2001. And the focus originally was, how can we better serve a specific population of patients who repeatedly readmit to the hospital? And as we know, readmissions are very expensive, very challenging, and very damaging to one's quality of life. So just in the small pilot that the group was able to do back in 2001, we were able to demonstrate a 75% reduction in rates of rehospitalization for that cohort. And it was really a very small cohort. So from there, it's expanded. We added another chronic disease population, COPD, and again saw similar results. And so from there, as the technology has grown, our program has grown. And so we really try to roll this out to our populations throughout our service area, which, as you heard in the introduction, is very elderly, very rural, and lots of barriers to care.
So Danielle Lauder, Program Director for the Northeast Telehealth Resource Center. We are one of 14 federally funded resource centers, HRSA's Office for Advancement of Telehealth, specifically under the Federal Office of Rural Health Policy. So we tend to serve a lot of rural and underserved areas. Collectively, we cover all 6 New England states, all of New York State, and the northern half of Jersey. So we are busy, and it's very diverse. As Bill, I think, mentioned early this morning, if you know one rural community, you know one rural community. Same is true in respect to telehealth and the policy, the legal and regulatory pieces. We're funded to provide technical assistance typically to health systems, providers, policymakers, all of the various stakeholders, and we rely heavily working with partners, a lot of whom are in this room, to inform policy, change policy that may be a little bit limiting in respect to the expansion of telehealth. There's a lot of wonderful efforts going on here in the state of Maine. We happen to be based out of Augusta, Maine. Fortunately, was born and grew up here, and I think, you know, as far as in respect to the relevance to aging in place, we're all aging in place. I'm a day older today than I was yesterday, right? So it's so relevant to every single one of us, and the more proactive we can be and to incorporate the use of technology, which has grown immensely. As Steve mentioned, their program is one that we mention as a wonderful case model with wonderful data on cost avoidance, et cetera, on every time we go out and speak. So there's so many potential opportunities, but there are some roadblocks in respect to figuring out how do you accommodate different workflows when it comes to telehealth, technology, et cetera, getting folks more comfortable. It's never really the patients who are uncomfortable with it. That's a very easy sell. A lot of times it's helping the providers with all of the other stuff that they have on their plate to really implement it well for workflow, with workflow and technology that works well for them. So it runs the gamut. We get lots of technical assistance questions in respect to policy, workflow, technology assessment. The technology is far and above, they're way ahead of the policy side to it. So we really get a lot of different types of questions from a lot of different stakeholders, and that's what keeps it interesting. And we would love for any of you to connect with us if you have additional questions.
Hi again, I'm Cheryl Crowley from Cliff Island. I talked a little bit earlier about being part of Sustainable Cliff Island, all things sustainable to keep us going as a year-round community. But even before we started that organization, I got involved in going to conferences with other islanders, small islands in the coast of Maine, to talk about elder care and what each island does or does not have. And beg, borrow, and steal ideas, much like we're doing here, but focus just on elder care. Well, the word telemedicine came up, and I was very intrigued by that. I had never heard of it before, and this is a good 10 years ago. And so really sort of a driving force to broadband for me was telemedicine and bringing that to our island, because we are remote. It's a minimal 3-hour round trip to the mainland, which can be really tiring. It's tiring for our teenagers, let alone our elder people. And so add any kind of illness or limitation to that, and it becomes a difficult project. And people will choose, well, it's not bad enough for me to go to town. And then you end up with a very sick person. By the same token, we've had people move from the island because their weekly trip into town just for blood work was too much for them. So again, sustaining ourselves as a year-round island, we just thought that this is one more piece to the puzzle, bringing telehealth to the island. So now that we have broadband services, I am very interested in expanding. I have to say, too, with bringing broadband to our island, our community unanimously voted to put an addition onto our community hall to house the broadband electronics. And in that area, we have a huge area for our new health center. Now, this is going to be a health center that's informal. We don't have practitioners there, but we will be able to invite people there and also to have our telemedicine there. So the group that brought us together to talk about elder care was the Maine Seacoast Mission, and they are very active in Penobscot Bay with their boat and telemedicine. And quite honestly, even more than doctor's appointments, are opportunities for counseling. And so anywhere in rural Maine, rural islands, this is a big need, as you well know. So kind of all-encompassing, and I'm really interested in going forward with that.
The joys of being the last person, right? So my name is Chris Winstead. I'm Executive Director for the Piscataquis County Economic Development Council. A lot of people know us as PCEDC because we love acronyms. We are a quasi-governmental nonprofit with our focus and goal of growing the economy of Piscataquis County. We are the most rural county in the state of Maine. We are also one of the largest counties in the state of Maine with a landmass the size of Rhode Island. What does that equate to? With our 17,500 residents, we have 4.26 residents per square mile. Kind of gives you an idea. So, I work with a lot of trees on economic development. Wanted to provide a little bit of humor. Everyone's looking a little tired this afternoon. Kind of probably wondering why I'm sitting up here as part of the conversation with telemedicine. And I was joking a little bit with some of the friends at my table about it's a little weird to put a economic developer in the conversation around telemedicine. Except for the fact that when you think about economic development, the other side of that coin is community development, right? So I used to use the phrase grow your own. With all of the changes in marijuana legislation in the state, I've decided to drop that, but really our lowest point of growth in our communities is working with our current businesses, right? Helping them expand. If we can get them to add 1 or 2 employees, it's far easier than trying to attract in a large-scale employer from out of state. For that to happen, 2 things have to be there. We have to have a workforce, and we have to have a community that people want to live in. So when you look at telemedicine, I really put that into the category as it's an asset that we have to invest in to keep our communities at a level where people want to reside there. Myself and Tanya Pereira, who's sitting at the middle to back table, we were involved with a group called Fusion Bangor before we call it menudoed out, but before we aged out of the group. And a lot of that was around fighting the brain drain, right? So when we think about working in our communities and starting to develop a community that is supportive of our seniors and making our communities a better place for folks to age in place, which is from an economic standpoint, the most affordable option. And from a community standpoint and a psychological standpoint, it keeps those connections for our seniors in place, which means they are with the folks that if we're dealing with someone with Alzheimer's, who's dealing with memory loss, the more that you can keep in place from a routine, the easier it is for them to manage their illness and manage their disease as they're going through their treatments. The more we can do with our communities to kind of allow folks to age in place, the better the fabric is, the more jobs we'll end up with because it keeps people in our communities. When I saw the statistics for Piscataquis County and looking out 10 years down the road and what our population numbers are going to look at, it gets a little scary. But it's a lot easier to start to look at our current population that's living there and say, okay, what are your needs? Where do we need to make the investments? If we make those investments, we keep you as residents, we keep you locally. It makes our communities more attractive, which means we have folks that want to live there. We keep these services local. 2 things, if your community loses, it's the final nails in the coffin, your hospitals and your schools. So when you look at rural healthcare and the challenges that are facing any of our rural hospitals or our FQHCs, our federally qualified healthcare centers, a lot of it is around attraction of new providers. So when they have someone that leaves, there's a huge challenge in getting someone to backfill that. So the more you can do with telemedicine, the ability for a provider to beam in and see that patient and keep them local, the more likely you are to see those local institutions continue to thrive. The other side of it, how many of us live in a community that has not, and emphasis on has not, been touched by the opioid crisis? So no hands went up. So how many of us live in a community that has been touched by the opioid crisis, right? So living in Piscataquis County, a lot of our folks, if they're going for methadone treatment or some of the other treatment options that are out there, have to leave Piscataquis County and drive into Bangor. Kind of dangerous when you think about putting folks on the road, especially if they're on their way home under the influence of methadone or some of the other treatment options that are out there. The ability to do telemental health and telebehavioral health services in those homes, in those communities, provide a far better way for us to reach individuals, get them into recovery, keep them in recovery, and put them back into the workforce. So I really, I look at telemedicine as a great way for us to invest in the community development side. Our job and our responsibility as an economic developer is to be there to help our local hospitals and healthcare clinics, whether it's helping them find grant funding, whether it's helping them find access to resources, or whether it's there to be part of the conversation regarding a needed build-out for fiber. That's kind of how I look at it. It fills that community development side of the coin.
Thanks, Chris. So I'm thinking before we get started on questions, maybe the most basic question, since I see your slide up there, and also I hear people using telehealth and telemedicine interchangeably, maybe it'd be helpful if, Danielle, I think that's your slide, just a quick one on what is telehealth?
Sure. So the telehealth resource centers, and certainly many folks across the country and globally, utilize the word telehealth because it's a much larger definition and it continues to grow on the daily. I would even say that more folks are starting to use the word digital health and digital health strategy. Telehealth really encompasses the different types of telehealth, and I also have a slide for that as well, and we'll share the slide deck with you after the fact. It has some live links with resources. But it's really the use of telecommunications technologies to provide care, education, provider to provider education is included under telehealth, the different types of primary care to specialty care, electronic consultations, MHealth. How many of us are wearing some type of MHealth, whether it's a smartwatch or something like that, or it's incorporated into your phone, is all really included under that definition of telehealth. So it's very broad under our definition. And there are several definitions that are utilized, but they're really quite similar.
And can you maybe also talk about the aspects of it that would require broadband?
Sure. So there's different types of telehealth. If we maybe couple slides here. The different types of telehealth, certainly video conferencing would require a larger broadband capacity. So that's traditional telemedicine is really the live video. In some states, actually, their rules and regulations require that you have both audio and video in order for it to be a reimbursable service. This is where broadband comes in. You need to have enough connectivity to exchange that audio and video at the same time. So that's synchronous or video. And then store and forward or asynchronous is typically you're exchanging data. Whether it's dermatology images, any type of images and other information that doesn't happen real time. So that doesn't necessarily require that level. And then, of course, remote patient monitoring, as Steve's team does at MaineHealth Care at Home and many others. A lot of times, again, involves exchange of data, and then they can actually help. It's typically with chronic illnesses such as diabetes, COPD, et cetera. But all day long, they're exchanging data with the team that can then prioritize who needs to go be seen, saving a lot of time, energy, and dollars for those who don't need to be seen, right? Their model actually includes an option for the patients to connect to live video. So their model actually needs to have that broadband capacity. Mobile health, which we just talked about, can be many, many different things from, the things that you wear on your wrist or your smartphone, et cetera. And then the provider to provider is a lot of times it's the asynchronous exchange of data, but it's also things like Project Echo. Are folks familiar with Project Echo? So it's a medical education model that does need broadband because you need a live audio video feed where primary care providers are really working with specialty care providers to present cases that are complex that they're seeing day in, day out in our rural communities, but they're not comfortable dealing with those on a day-to-day basis without connecting with a specialist. So they'll connect with them real time, and they'll get wonderful education, training recommendations for helping these patients. And they're building their capacity to keep those patients local. Things like hepatitis C, there's 50 or 60 different use cases for Project Echo, and I can tell you a lot more about it. But that's really the gist and the need for the broadband piece of
Great,
it.
thank you. Okay, so here's a question for all the panelists. What do communities need in terms of both infrastructure and policies in place to be able to support telehealth?
I really can't speak to the policy, but again, what we needed was broadband, and we now have it. So now it's figuring out what we need for the hardware to access it and utilize it in the best way for our community.
So in addition to nurse-based home health services, we also are doing more and more population health programming with our telehealth program. So for example, we have wellness clinics on Long Island and Chebeague Island, where we have a nurse who's in place a couple times a month, but we also have telehealth equipment there, and we invite residents to use that telehealth equipment to connect with our nurses, again, to get triage, to answer questions, just to have that connection again. So if they happen to miss the nurse the day before or a few days before, whatever it is, they still have that access to our team to get their questions answered.
So from an infrastructure standpoint, I think, what we would need is we would need fiber to homes, because let's take this out beyond just our healthcare clinics and our hospitals to the ability to help our seniors age in place. There's a really cool lab up at the University of Maine called VME, and I'm going to butcher part of this, virtual environment intermodal, and I'm missing one letter. I'll have to look it up before we're done. But there's some really cool technology that's come out of VB, including the ability to have sensors in your floor. Why is that important? Well, that's important if my grandmother falls, right? That individual hits the floor. We now know, and we can dispense medical care directly to them. So when you think about some of these things that allow us to age in place and allow us to access that health care in our own communities versus having to travel, we need fixed wire or wireless to the homes, but we need to be able to connect our folks in their place of residence to be able to access these services. Years ago, my first engagement with the conversation around telemedicine was actually touring the VA facility up in Calais, and we walked into a room that was set up with a video conferencing. And I kind of tilted my head a little bit, and I was with a former member of Congress, and we both looked at this and said, telemedicine, ? And they said, yes, mental health services, the ability to actually have some of those veterans who are dealing with PTSD reach out to providers in Augusta. They would have had no chance to get those providers up to Calais. It would have been a challenge to find those providers locally to provide those services to those veterans. So they were using telemedicine to deliver on those services. So, I think if we look at, from a cost standpoint, two things have to happen. We need to, and this gets to the policy side, we need to look at increasing the reimbursement rates for our rural hospitals and our FQHCs. It's the only way that the dollars and cents work. The second piece is looking towards telemedicine, increasing the reimbursement rates so that maybe we can use some of those funds with hospitals and pair them with some other subsidies to build out those networks in our communities with a hub and spoke model that allows for delivery of these services. And I think, finally, the third one is we need to get folks comfortable with that when you're sitting with that provider and it's a digital presence, that it is the same interaction that you have just like sitting in front of that physician. Because that's one of the major barriers, I think, for folks is when they sit down in front of that screen, especially when we're talking about the behavioral mental health as well as any of the recovery services, being comfortable that that person is paying attention, that they're engaged, and just because they're not a body in that room, they're still going to provide that level of service.
I could speak just a little bit more to the policy question because it's by far the most common questions that we get. It tends to be a little complex. We're very fortunate here in the state of Maine. We have one of the most progressive telehealth reimbursement policies in the entire country. But of course, there are differences between our private and our public payer. So that creates confusion and complexity among our healthcare partners in actually implementing it, right? So MaineCare actually has payment parity, which Chris had mentioned is really important. They pay at the same level as they would in person. Our private payer policy does not have payment parity. They have coverage parity, which means that they must cover it if they would cover it in person, but they don't have to pay it at the same rate. So it's working toward, and we have a lot of great folks working toward getting rid of that diversity in the policy, because it's just going to be that much easier to use and expand through our healthcare partners. Medicare is Medicare, so they have their own set of rules and regulations around reimbursement for telehealth. They put some requirements or restrictions on it. For example, Maine, much of Maine is rural, right? So, but they do have a geographic restriction on reimbursement for telehealth services that in most cases you have to be in a rural eligible area, zip code, right? And they only, they have a list of providers and a list of CPT codes that they will reimburse for telehealth. And it is what it is. And if you're outside of that, then they won't reimburse for that particular service. So just make sure, you don't have to be aware of all of this, but come to us when you're ready to implement, and we can help you walk through some of the issues and just making sure that that you understand what some of the restrictions and what the opportunities are. It's also about local policy. We have folks getting really innovative. There's a group out of Finger Lakes, New York that we've worked with for a number of years. Their screening rates for their adults with diabetes for retinopathy were very, very low. They were abysmal, as they would put it. And they serve a large migrant population, and they decided to try telehealth as part of their regular primary care visit. They incorporated a retinal screening for all of their adults with diabetes through the roof. They didn't have to go to another provider. They were sending the data to an ophthalmologist for a very affordable fee, and they were actually able to negotiate an incentive payment with their with one of their regional ACOs or accountable care organization to get payment back because they were meeting those quality metrics. So it's just thinking outside the box. And I know, Maine communities, that's what we're good. We're really, really good at that, thinking outside the box, getting innovative. So.
I look at it as not replacing the need for healthcare, because you're still going to have someone that's going to be there with you. So whether it's a nurse, a CNA, a nurse practitioner, you're still going to have that interaction with a real human being in person. And I think, having the right people there that can kind of make you feel comfortable, and depending on the situation, help you engage that provider on the other end. It can be a huge cost savings. I'll actually use a personal example. So my dad he's a diabetic, has had major health issues, has a specialist that he sees down in Massachusetts. In August, had this horrific side effect that went into place, was admitted at Northern Light. And the choices that they had at that point were either fly dad to Boston to see his specialist or have his specialist dial in. So dad was able to stay in Bangor, which means mom was able to stay with dad. And we all know that if mom can stay with dad, both parents are a lot happier at that point. And was interacting with his specialist in Boston over teleconferencing. A lot of the higher end rooms at Northern Light now have the teleconferencing set up in the room so that those docs can actually beam in and look at those patients. So, it's a huge cost savings, it's a huge time savings, and it increases quality of life. So I think it's all about getting folks to help make those patients comfortable. How many of us have a cell phone in our pocket, right? How many of us live our lives off of those cell phones? How many of our parents and grandparents have cell phones that they use, right? This conversation 20 years ago, you would have had a lot of folks that said, it's not really my thing. I don't need to be on Facebook. Look at how the times have changed.
Yes, so our experience with that is we find that there's a lot of underlying anxiety for a lot of the patients at home, and probably a lot of the success of the program is that we're able to keep in touch with them on a regular basis. We're able to engage them on a regular basis, where it wouldn't be feasible to have a nurse go out and go into the home every single day, or even multiple times a week. And we're aware that there are people who respond well. Essentially, our program is we give them a tablet, so just like a phone, it's fully functional. It's a telephone, it's a text device, it's a video conference device. So a lot of patients are very comfortable texting with us, and you can sense the anxiety in the messages that you start with to after you've engaged with them a little bit. You can sense that, okay, they're understanding, they're coming back down to earth. There's a lot more comfort there. You can certainly hear that in a telephone conversation, and then more and more as we do video consults with our patients and video assessments, we're able to see that level of comfort grow. And interestingly enough, we're working with a research group out of Maine Medical Center that's studying that exact phenomenon. So what is the emotional response, the physiological response of having a palliative care teleconsult versus a palliative care in-person consult? So we hope to have some pretty good information about that upcoming.
I would just add that in a lot of studies with mental and behavioral health, particularly in adolescents, if you can imagine, we're born with technology in their hands, right? They're actually more comfortable with the technology version of that consultation, of that visit. Obviously, you're looking for continuity of care. You want to make sure they can stay connected with the same provider for long term, because that's really important. But a lot of the younger generation doesn't have a primary care physician, doesn't want a primary care physician. It's more the direct to consumer. They're calling, American Well or any different number of vendors for $50 out of pocket, and that's how they're having their consults. Certainly, telehealth is a tool in the toolbox. It's not meant to replace people or health systems, et cetera. It's really but I think it's an expectation. We're starting to get a lot more questions from universities and colleges. Can you help us build curriculum that will help our providers of all different types be prepared to go into the healthcare workforce, knowing how to use this technology instead of having to catch up? We do a fair amount of training for providers who are already out there providing care, but it's easier if we can get them on the front end.
Do you want to add, Cheryl? Okay, great. So let's go to any questions from the audience. Right over here, and then back there. Oh, sorry. Hoarding them.
If you want to write your questions on the note cards, we can collect those too while we're doing a couple of in-person questions.
So, as a veteran and a beneficiary of the Department of Veterans Affairs, we have the My Healthy Vet program that provides us access to all of our records, whether it be an MRI or what have not. And when we go in to see our providers, one of the first questions, the nurse asks us when we arrive is, do you know about the Healthy Vet program? And, whether we answer that yes or no, they then ask us, do you have access to high-speed internet? Well, for many of us in rural Maine, that answer is quickly no, and we're immediately excluded from a fantastic program, nationalized healthcare. We're the beneficiaries of a nationalized healthcare program. We're excluded, and the VA has done a really great job of being progressive thinkers, moving this conversation forward and implementing, the infrastructure at the VA to be able to, work with veterans to provide this additional, means of accessing healthcare. And at the state level, we're being essentially impeded, from accessing that. And my question for you all is, have you used the, VA's My Healthy Vet program as a model for telehealth in Maine?
So I can sort of answer that question on a funding parity, if you will. And I'm kind of bummed I have to run up to Bangor right after this, so I won't be able to stay for the funding conversation. But you heard Commissioner Johnson talk about multiple funding sources that are needed to expand broadband in the state, right? I think that telemedicine becomes one of those sources that can provide some funding. So on the federal side, some of the programs, whether it's through CMS, the VA, others, there are funds out there that help their patients access telemedicine, telehealth. And I think if we start to look at those and aggregate those with some of our other funding sources, it becomes one way that in some of our more rural communities, we could actually build out connectivity to be able to deliver on those sources so that our veterans, our seniors, everyone can access the same level of health care.
Yeah, we also see VA patients, and we'll refer them to that program because it's wonderful, and they do offer a lot of information and a lot of services through that program.
The other thing I would say, and that it becomes an equity thing, but thinking outside the box is not as perfect as being in your own home to receive the care. However, if there's a community location, like the folks on Cliff Island are preparing, that you can be there in 5 or even 15 minutes versus traveling 3 hours. Work with your community to make those things happen, and then you can access, say, no, but 5 minutes away, I can go to this brand new spot that's been created for. Now it's the VA, so you want to make sure all your T's are crossed and your I's are dotted in respect to HIPAA and high tech and security and confidentiality and all those different pieces. But we could help you out with that if need be.
Hi, Sue Woods. I was on the national VA team that opened up all the notes in January of 2013. I'm so glad you brought it up. You should not, anybody who's a veteran can get registered on MaineHealth Vet. If they're telling you that you can't because you don't have access, you come see me, because that's not true. Is getting it, yeah. Well, that's where caregivers and friends and going to work and the public library come into play, because but I just want to say digital health also means getting access to your portal and being able to see your own data. VA is one of the only places in Maine that has open notes where you can get access to your doctor's notes, so it's a huge opportunity.
Okay, I'm going to go to one of these questions that was written down. Are there other barriers to digital health services access other than broadband? For example, cost or access to hardware devices?
I would have to say providing a place on our island for community to come and access the services. Ours is hardware, and also getting some kind of a secure HIPAA line. So those are the things we'll be looking at soon.
I would say yes, when we're talking about the affordability, right? And when we've kind of skirted this conversation a little bit today, but affordable access to healthcare. We think of a lot of our senior citizens who are living on fixed budgets. And when you start to talk about, okay, how do we connect you, and whether we use one of the subsidized programs that are out there or not, I think we have to get a little more creative. And maybe that's a case where we look at those properties and we say to their service provider, okay, for my grandmother to stay in her home, maybe she cannot afford broadband. You have an affordable, provision that's there. You have a subsidy that's there, but maybe there's still a gap, right? How can we find a way to get those individuals connected and find a way to have it be sustainable long term? So I think, yes, affordability comes into mind. I think proximity is another thing. So I mean, even with the connection standpoint, if you're talking about some of our most rural areas, there are roads that we're not going to be able to connect. And due to topography and mountains and trees and rocks, fixed wireless may not be a solution either. So, I think we will continue to run into challenges just because of the way our state is.
Question back here.
I'm not so sure of a question or just to kind of help with this telemedicine. My daughter, who allows me to share this for the greater good, has a provider that she sees once a week. And living on an island, she missed 3 to 4 hours of school each week to see a provider. We do have fiber to the home, and she is now able to see a provider via a platform that MaineHealth has set up in our home for an hour once a week, and it can be at night because there's nighttime hours. So we save ferry fare, lost time from school, fuel, and a whole nother other things that really makes it possible. And the only thing we needed was either a cell phone or a computer. That's all we need.
Yeah, it's great to hear about things like that, and we definitely hear that there are programs, there's people out there who are making things like that happen, and that's wonderful. But it's hard to see how do you make that widely available to a large population. Reimbursement is one barrier. I know physicians have their own reimbursement scales and schemes. As a nursing agency, however, we receive no reimbursement from any payer other than MaineCare, interestingly enough. So that's been a major barrier for us, in as much as the rurality and the access to broadband and wireless services. Our ability to recoup the cost of the services is a major barrier that we feel like there's steps being made, particularly by Medicare. About 80% of our patients are Medicare patients, and they are starting to look more seriously at it, so we hope that that's coming soon.
So we're all communities here that are trying to build the political will to fund broadband projects. In Cliff Island, there was a specific use case that you identified that probably helped a lot with bringing over that group. How do we as communities find those specific use cases that apply to our populations and that are actionable or available through the medical providers that actually provide our populations?
No, I'm going to think about this for a second. I'm not sure how to respond to that.
Particular use cases, I think, use your data, use the real life stories, like the gentleman just talked about his daughter back there, the cost avoidance, the cost savings, the quality of life. Talk to your policymakers. They want to hear from you. Some of the legal and regulatory, some of the reimbursement restrictions that are currently in place, sometimes it's just one or two words in the language that weren't intended as barriers, but they're there. So having those conversations with your legislators, to make either local policy change, state, federal. As Steve mentioned, Medicare is making some big changes, and we hope that those are going to move more quickly than in the past. But it's really about having those conversations, forums, utilizing your community health needs assessment data, those types of things, so that you can show the need, the why, I guess, is really important.
I think when you look at your planning committee, you want to make sure that healthcare is represented. We talked about education, healthcare, go beyond your hospitals, go into your FQHCs, your federally qualified healthcare centers, go into your private practices, go into any of your nursing homes, get that representation. If you have folks that work in some of your, the senior centers, include them in that conversation, because we really want to talk about, getting people to access these services. We're really fortunate in the state that our federal partners, our representatives and our senators are great resources for us. I know we have staff here from Senator King's office and from Senator Collins' office. I don't know if we have anyone from our representatives that are here, but they're good resources to bring into the conversation. They can help you access some of those different federal questions that you might be scratching your head and going, huh? That's why they're there. So, I encourage you, when you look at your planning committees, try to get as many people present and on that committee as possible. Think of the populations that you have in your communities. If you have an immigrant population that lives in your community, it makes complete sense that you would have a representative on that broadband committee representing that population. Same thing with healthcare. If you have a hospital, one of the first people you should be calling is their IT person that says, okay, we'd love for you to be engaged in the conversation. We're not asking you to pay for things, right? Like, that's the most important thing to start that conversation. But we need to know from you, well, because I think a lot of times when we reach out to hospitals, a lot of our hospitals, if you read the newspaper, are in financial challenges, right? Like, that's not a surprise to anyone. And a lot of it deals with the reimbursement rates. and the ability for them to have full payment for the services that they provide. There's a lot of charity care that these hospitals and healthcare clinics provide to their patients. If you have them engaged in that dialogue, they can help provide a better understanding of what truly is needed. So when you're looking to do that build out and you say we want fiber to the home, fiber to the premises, or we want fixed wireless, or whatever that solution looks like, you want to make sure that the technology can provide those services.
Cheryl, are you going to respond?
So I hesitated to respond because, my situation I feel is so simple. I'm only dealing with 50 people, but it's having those very personal stories that really speak to the greater population of people. You have your movers and shakers, but then those stories are the things that paint the picture.
Okay, I'm going to go to one more on the card. Thank you to Danielle for including teens in the telehealth discussion. Kids and young adults with medical appointments usually also mean a parent taking off time from work to go to the appointment. What changes, Danielle, are you seeing coming in how medical records are moved between providers? Often, previous specialist visits time is wasted because, is wasted because they haven't received patient records and test results yet.
Sure. And that's a challenge with telehealth workflows, certainly can be. But again, as health systems, including rural health clinics, FQHCs, et cetera, and the vendors, the telehealth technology vendors, become more systemic in their thinking, it doesn't mean that everybody has to have the same electronic health record. That is never gonna happen. It's never gonna happen because there are some that are super pricey, and then there are some that are more affordable, and some that have bells and whistles that others don't need, et cetera. But they're talking to each other. There's interoperability. We're getting there in that respect. So I would say it's really important that continues. Electronic consultations is a model of data sharing. And was it Dan, the cow, the vet, perfect example of an electronic consultation or an e-consult. He didn't have to leave his farm, take the day to travel back and forth there. So it's, and typically there's a system, there's a platform for sharing that data. And that's really about that primary care physician or provider, NP, et cetera, providing data to that specialist, whether they be a cardiologist, a dermatologist, et cetera. Asynchronously, they look at the data, could be scans, any different type of information, provide a recommendation back for treatment plan. So that primary care provider is still responsible for that patient, but they're feeling a lot more informed. They've built a strong relationship with that specialist, but you got to use those tools. You got to have access to those tools, and we're getting there with the interoperability. So hopefully that answers the question.
Great, thank you. We have our last question.
Oh, we got the last one. Thank you. My name's Seth Berry, and I just want to point out that there are some policymakers here. Policymakers were mentioned a moment ago. There are three of us from the legislature's Energy, Utilities, and Technology Committee, which oversees Connect Maine. Nicole Grahowski, representative from down in Ellsworth, Chris Chiazzo, representative from Scarborough, and myself. And then we also have the Senate Republican leader, Dana Dow, as well. And I understand that Representative Golden's office was represented here, maybe still is. They were here for most of the day. Please think of us as not just a resource, but also, yes, do come and educate us. I think that if more legislators understood telehealth and some of the individual stories of, lives saved or improved by telehealth or digital health, I'll call it now, it would definitely help us to have greater will to fund Connect Maine and to fund the bill that we need. We did pass LD 1263. Which sounds like it may not fix the entire solution around private coverage, but hopefully gets us a step in the right direction starting in January around covering this. And then also we did, I think it's important to acknowledge the budget roughly tripled the Connect Maine's authority's annual budget. The bond failed, but we're going to come back at that next year. But keep on telling us these stories, because I think it really is the powerful stories of how the internet is useful for more than just Facebook. That's incredibly important. Really improving lives. That's what will make the difference. And tell us, if you want to now, what can we do at the state level to help to advance the ball? Tell us now or tell us later.
I
How
think
about
just
really quick?
keep going. I would,
Yeah.
as I mentioned before, Maine has one of the most progressive policies, private payer and Maine Care. We added asynchronous or store and forward to the private payer policy with 1263, which is awesome. We added RPM, remote patient monitoring, to that coverage, which we hadn't had in the past. So thank you for listening and changing. And they need to hear these stories in order to make sure that the legislation, the bills that they're putting in are well informed. So thank you for saying that.
Great. Well, thank you very much.